Hyperbilirubinemias. The normal total plasma bilirubin level is 0.2 to 0.8 milligram per deciliter, in which the unconjugated bilirubin is 0.2 to 0.6 milligram per deciliter and conjugated is 0 to 0.2 milligram per deciliter. If the plasma bilirubin level exceeds more than 1 milligram per deciliter, it is called as hyperbilirubinemia. Whereas if the levels are between 1 to 2 milligram per deciliter, it is called as latent jaundice. And if the bilirubin exceeds more than 2 milligram per deciliter, then it diffuses into the tissues, producing yellowish discoloration of the sclera, conjunctiva, skin and mucous membrane, resulting in jaundice. Jaundice is the clinical term and icterus is the Greek term for jaundice. Coming to first, congenital hyperbilirubinemias. These congenital hyperbilirubinemias result either due to abnormal uptake, abnormal conjugation, abnormal excretion or secretion due to inherited defects. These are again classified into two different types, conjugated and unconjugated. The two syndromes which come under conjugated hyperbilirubinemias are Dubin-Johnson syndrome and Rotar's syndrome. We can remember these three with the help of the mnemonic CDR. Dubin-Johnson's, Rotar's coming under conjugated hyperbilirubinemias. Whereas the unconjugated hyperbilirubinemia has two syndromes, CRIGLER-NAJJAR syndrome and Gilbert's disease. Firstly, the Dubin-Johnson syndrome. It is an autosomal recessive type of inherited disorder. The basic defect here is the defect in the secretion. So there are four different stages in the bilirubin degradation. One, when the bilirubin is taken up by the liver cells or the hepatocytes, and in the liver the bilirubin undergoes conjugation, and after conjugation the bilirubin is secreted into the bile, and then from the bile it is excreted into the intestine. So the defect here lies at the level of secretion. Now why is the defect in this at the level of secretion? Is because of the mutation in this MRP2 protein, which is mainly responsible for the transport of conjugated bilirubin into the bile. The bilirubin gets deposited, the conjugated bilirubin, it keeps on getting deposited in the liver, and the liver appears black, and that is why this condition is referred to as black liver jaundice. Next is Rotar's syndrome. It is also an autosomal recessive type of inherited disorder, and here the defect is at the level of excretion. So here in the Dubin-Johnson syndrome we have seen the defect is at the level of secretion, whereas in Rotar's syndrome the defect is at the level of excretion. That is, the bilirubin is not excreted from the bile into the intestine. So there is an increase in the conjugated bilirubin type, but there is no staining of the liver. Next is the unconjugated bilirubinemias. First one is CRIGLER-NAJJAR syndrome. It is also an autosomal recessive type of inherited disorder. There is the defect in conjugation of the bilirubin. The basic defect here lies in the conjugation of bilirubin. Now there are two different types of CRIGLER-NAJJAR syndrome. Type 1 is complete absence of the enzyme UDP glucuronide transferase, which is responsible for conjugation, and type 2 is partial deficiency of the enzyme UDP glucuronide transferase, because of which there is partial defect in conjugation. In type 1, jaundice usually appears within the first 24 hours of life, and unconjugated bilirubin increases to more than 20 milligram per deciliter, which results in kernicterus. And the disease is often fatal, and the children die before the age of 2. Whereas type 2, because there is only partial deficiency of the enzyme, the unconjugated bilirubin level is less than 20 milligram per deciliter. This is detected later in life, and kernicterus is rare. And barbiturates are given to stimulate the enzyme UDP glucuronate transferase. And the next disease which comes under unconjugated bilirubinemia is the Gilbert's disease. It is also an autosomal recessive type of inherited disorder. This is the result of combination of defects. The disease results either due to defect in the uptake of bilirubin by the liver, or because of the reduced activity of the enzyme UDP glucuronyl transferase, or defect in the hepatic clearance, that is from the liver to the bile. Bilirubin level is usually around 3 mg per deciliter and the patient is asymptomatic except for the presence of mild jaundice. Thank you.